Yes, I'd like to talk about the International Society of Nephrology. It's a nonprofit professional organization dedicated to advancing worldwide kidney health. The ISN strives to bridge the gaps of available care through advocacy and collaborations with their global partners to build capacity with healthcare professionals and granting programs, education, and research opportunities, and to connect communities in order to develop a stronger understanding of how to manage kidney diseases and engage in a collaborative effort to improve prevention, diagnosis, and treatment. The International Society of Endocrinology was established in 1960 to advance the profession and to improve the efficiency and effectiveness of endocrinology information exchange at an international level. Its membership currently comprises national endocrine societies from 76 countries, representing over 50,000 endocrinologists worldwide. And so there are going to be a number of learning modules that we're going to have on diabetes and the kidneys. The first that you'll see today is management of diabetic patients during the COVID epidemic. We'll have a second seminar in September. They'll talk about the current management of diabetes in patients with kidney disease. And then finally, webinar number 3 in November, we'll talk about the recent and upcoming clinical trials in diabetic kidney disease. So just to introduce our topic today, diabetes certainly is a major risk factor behind the escalating prevalence of non-communicable diabetes diseases and the increasing mortality and morbidity attributable to them. A predisposition to development and poor outcome of infectious diseases in the presence of non-communicable diseases has been noted, especially with increasing morbidity and mortality from COVID-19 in patients with diabetes have been noted in countries hardest hit by the pandemic. And this association and the optimal management of infected patients with diabetes deserves close scrutiny, and this will be addressed in this webinar. Kidney disease, particularly diabetic kidney disease, certainly has an increasing prevalence and is a major cause of mortality and morbidity. The presence of chronic kidney disease is associated with both inflammation and increased risk of infectious complications, and has been anticipated to predispose to increased risks associated with kidney disease and adverse outcomes from COVID-19 disease. The impact of COVID-19 on kidney, association of kidney disease with outcomes, and management of COVID-19 disease, and considerations for the outpatient management of kidney disease in patients in the setting of the COVID-19 pandemic will be reviewed. So our speakers today will include first Dr. Kutsi. She's a specialist physician and subspecialist consultant and senior lecturer in diabetes and endocrinology at Stellenbosch University, Cape Town, South Africa. She completed her undergraduate studies in 2005 at the University of Pretoria. She then joined the Stellenbosch University Division of Endocrinology as a senior house officer in 2008, where she completed her intern and specialist training as a specialist physician in 2012. She subsequently embarked on her fellowship in endocrinology and also completed an MPhil degree in gestational diabetes field in 2018. Her current research interests include hyperglycemia in pregnancy, diabetic emergency and obesity, and she's currently the president of the Society for Endocrinology, Metabolism, and Diabetes of South Africa. So she will be discussing the effect of diabetes mellitus and COVID-19. So now, Dr. Kutsi, please proceed.
Thank you for the very, very kind introduction. And as Dr. Molich have said, is I'm from South Africa. I'm sure all of you attended the ISE conference in Cape Town towards the end of 2019 when we were still able to travel. I have no disclosures for the purposes of this talk. So just to sort of bring the topic home, infections have harmed people for millennia, but pandemics of viral origin, such as the Spanish flu in 1918, seem to pluck at our most primal fears. So here we are again. And what distinguishes the SARS-CoV-2 virus from the previous viruses that caused pandemics is that it's a new pathogen in humans, meaning that we are all immunologically naive to it. Now, in contrast to the Spanish flu of 1918, which occurred at a background of famine, this current COVID-19 pandemic occurs at a background of high rates of obesity and diabetes. And due to this collision of pandemics poses unique challenges. Today, I will be covering the following talking points relating to COVID-19 and diabetes. Now, I'm sure all clinicians have recognized clinically that people living with diabetes are at a specific increased risk of infections. And the reasons for this is multifactorial. It includes associated comorbidities and the complications, micro and macrovascular complications of diabetes. But in addition to this, hyperglycemia per se compromises both the innate and the adaptive immune response. And this makes the first line of defense against any infection, including the SARS-CoV-2 virus, in people with hyperglycemia inefficient. Now, as is shown in this slide, in diabetes and in obesity, both the innate and the adaptive immune systems experience significant derangements as a result of chronic inflammation. And when we superimpose diabetes with infection, there are synergistic and antagonistic changes in this immune response with dysregulation and suppression that in fact sort of leads to an inability to return to homeostasis. And I'm sure we all see this in clinical practice. Now, this retrospective study that's currently appearing on your slides compared just over 100,000 English primary care patients with diabetes to age and sex matched control subjects without diabetes. And it just confirms the higher rate of infections and the higher risk for adverse outcome in both people with type 2 and type 1 diabetes compared to controls. Now, this increased rate of infections seem to be more bacterial and fungal, with bone and joint infections, sepsis, pneumonia, and cellulitis having the highest incidence rates. Now, as opposed to bacterial disease, data on incident viral disease in people living with diabetes are quite limited. The pulmonary system, having the largest capillary network in the body, are increasingly being recognized as an end organ that is also affected by diabetes. Now, abnormalities in the pulmonary vasculature has been demonstrated with decreased pulmonary transit of agitated contrast bubbles in diabetes, and this especially occurs in the presence of other microvascular complications. But as is portrayed in this slide, over and above the vasculature, there's changes that occurs in the lung volumes and with regards to diffusion capacity in people living with diabetes that predisposes to pneumonia or lung infections. In addition to this, the lung expresses the ACE2 receptor that serves as a coronavirus receptor, and the lungs is the primary organ affected by COVID-19 infection. And as we know, following entry into the pneumocyte, the SARS-CoV-2 virus replicates, downregulates ACE2, and there is a consequent loss of the protective effects in any person infected by the SARS-CoV-2 virus. Now, in recent years, a combination of various epidemiological and histological and animal studies has really strengthened the evidence for a role for enteroviruses to be causal in type 1 diabetes. And we know that similar associations exist between type 2 diabetes and the hepatitis C virus. Now, diabetes and renal disease is very well recognized risk factors that was associated for mortality in other coronavirus infections with specific reference to the SARS and the MERS viruses. And there are various theories to support the increased risk of infection with SARS-CoV-2 in people living with diabetes. We've mentioned that the ACE2 receptor is the main host cell receptor for the virus and that it plays a crucial role in viral entry. in a situation where there's an abundance of these receptors, this might lead to an increased viral load, and this is the basis of various theories that suggests that people living with diabetes might have risk factors for increased ACE2 expression, such as obesity that's been associated with a higher rate of ACE2 receptor expression in the adipose tissue, suggesting not that the adipose tissue has a higher expression per volume, but suggesting that due to the abundance of adipose tissue, there are more ACE2 receptors present. Various drugs are associated or used in diabetes are associated with an upregulation of the ACE2 receptor. And in mouse models, it has been shown that there is increased expression in the context of hyperglycemia of the ACE2 receptor in various organs. People living with diabetes are far more likely to require hospitalizations with other viruses as well. And in this slide, I'm demonstrating that in vitro, there's a dose response increase between increased glucose concentrations and increased replication of the H1N1 virus in red on these slides in pulmonary epithelial cells, suggesting that hyperglycemia has direct consequences with regards to viral replication of the H1N1 virus. It has also recently been shown in a study from Brazil that's yet to be published in Cell Metabolism that elevated glucose and sustained aerobic glycolysis in monocytes also actually promotes SARS-CoV-2 viral replication via a mitochondrial hypoxia-inducible factor-dependent pathway, and this in turn results in T-cell dysfunction and epithelial cell death. Now let's move to real patients. And what I'm showing in this slide is a meta-analysis of 12 studies from China. And what is demonstrated in this meta-analysis is the prevalence of COVID-19 infection and people living, or a co-presence of diabetes and COVID-19 infection. And as you can appreciate from this meta-analysis, the prevalence of diabetes and COVID-19 was roughly 10%. So the question is, are people with diabetes more at risk to contract COVID-19? If you compare this prevalence of COVID-19 in people with diabetes with a nationwide diabetes prevalence in China, you can appreciate that there's not much of a difference. I apologize for that. When we move to Italy, the prevalence of diabetes and COVID-19 is around 8.9%. And when you compare that to the regional diabetes prevalence in this single center study, you would note that these figures also overlap. Now, this suggests that the background prevalence of diabetes is reflected in the presence of COVID-19, and that people living with diabetes are not necessarily more susceptible to COVID-19, but that it might just reflect the background prevalence of diabetes. Now, in order to draw definite conclusions on the susceptibility, we obviously need larger studies from more than one geographic location and with preferably accurate prevalence figures for diabetes mellitus per se. Now, to date, around 8 meta-analyses have assessed the severity of COVID-19 in people living with diabetes. But the limitations of these studies include the classification of severity of COVID-19 and the comparator varied. In this slide, however, the Center of Disease Control from China reported a case fatality rate of 7.3% of people living with diabetes and COVID-19, as compared to a case fatality rate of 2.3% in the background population, suggesting that people living with diabetes have a risk to have more severe disease. A retrospective observational study from 88 hospitals in the United States involving roughly 570 adults with COVID-19 also evaluated outcomes in patients with and without, this is with and without diabetes or uncontrolled hyperglycemia. Uncontrolled hyperglycemia was defined as 2 or more blood glucose values that exceeded 180 milligrams per deciliter or 10 millimoles per liter. With an HbA1c that is not indicative of diabetes. And what you can appreciate from this chart is that there was a significant increased mortality rate of 28.8% in individuals with diabetes or uncontrolled hyperglycemia, compared to a 6.2% mortality in individuals without hyperglycemia or diabetes. What is more, and what is demonstrated in this slide, is that in individuals with diabetes or uncontrolled hyperglycemia, there was a significant increased length of stay in hospital as compared to diabetes with people without diabetes or uncontrolled hyperglycemia. And this is really something that we have to take note, considering the finite number of resources that we have available for the management of people with COVID-19. It's also been well recognized that type 1 and type 2 diabetes are phenotypically distinct entities. There is some overlap, but for practical purposes, we know that the one is mostly insulin resistance, and the other one is mostly absolute insulinopenia. Now, in a population-based cohort study from England, they aim to assess what the risk factors are of in-hospital death due to COVID-19. And this orange block specifically looks at the risk for mortality in people with type 1 and type 2 diabetes. And what is novel from this study is that in this time frame observed, even after adjusting for age, sex, ethnicity, and socioeconomic status, people with type 1 diabetes had a similar increased, or had also had a significant increased risk of death, suggesting that the adverse outcome is not limited to people with type 2 diabetes. An important limitation of this study, however, was that it did not include or document data with regards to the presence of chronic kidney disease or acute kidney disease that is a significant contributor to mortality in people living with diabetes. And what happens to insulin requirements? And it seems that insulin requirements generally increase unless there's confounding variables such as the use of chloroquine or acute kidney injury that decreases the secretion of or decreases the metabolism of insulin. And in this case series by Gu et al. From confirmed that there's significant increase in insulin requirements, and in 40% of people with pre-existing diabetes, they require the first-time initiation of insulin. A limitation in this study, however, is that we do not know what the glycemic control was that preceded this hospital admission in this patient. So it is possible that a lot of these patients were actually uncontrolled prior to this admission. Another factor that's coming from various studies is the increased risk for diabetic ketoacidosis in the presence of infection with SARS-CoV-2. From the pathophysiology of hyperglycemic emergencies, specifically DKA, we know that it depends on both insulin deficiency and the increase in counter-regulatory responses. And it is therefore, on a pathophysiological basis, very plausible that any infection, including SARS-CoV-2, can decrease insulin secretion and increase counter-regulatory hormonal responses. In the setting of obesity with the increased interleukin-6, this also contributes to the increase in the counter-regulatory hormones. Now, in clinical practice, we appreciate the following clinical scenarios with relation to COVID-19 and DKA. Firstly, we find that there's a high proportion of patients that have been undiagnosed with diabetes, and the hyperglycemia are unmasked in them with the co-presence of COVID-19. We also see individuals with pre-existing type 1 diabetes who have COVID-19 and require hospital admission for either or a combination of the two. And we are increasingly seeing this entity of people with type 2 diabetes that presents in DKA without antibodies, and the so-called ketosis-prone phenotype that is tipped over into this metabolic disarray during COVID-19 infection. It is important to also remember that in individuals with diabetes, there's other reasons for a high anion gap metabolic acidosis, such as acute kidney injury that the next speaker will address, and that medications used for COVID-19, such as the glucocorticoids, can significantly contribute to this counter-regulatory response, increasing insulin requirements in individuals with and without diabetes. Now, SARS-CoV-2 can have a direct effect on the islets. And as you can appreciate from this little cartoon, the ACE2 receptor is expressed in more or less equal amounts in the lung in green and in the pancreas in brown. The ACE2 receptor expression seems to be more in the endocrine pancreas as opposed to the exocrine pancreas. Now, with the direct effects, it is plausible that it can cause diabetes, but indirectly, due to this downregulation of ACE2 with infection with SARS-CoV-2, you get an unopposed angiotensin II, which has been shown that it impedes insulin secretion by affecting pancreatic islet blood flow. This, interestingly, can be rescued by RAS antagonists, but also it dose-dependently inhibits insulin release from mouse islets in response to a high glucose concentration, suggesting this is something that might be reversible. Mortality in COVID-19 and DKA also seems to be significantly higher than what we have seen historically. In this study from the Jacobi Medical Center in New York, the mortality rate of individuals admitted with diabetic ketoacidosis was roughly 50%. So 1 in 2 individuals with DKA and COVID-19 did not make it out of hospital towards the end of this study. A significant proportion of individuals, more than 2/3, with COVID-19 and DKA also developed acute kidney injury, and roughly 1 in 4 patients require renal replacement therapy. So it is certainly plausible that SARS-CoV-2 can cause diabetes, but we need longitudinal studies to assess beta cell function, etc., etc. And I hope to read about this more as the pandemic evolves. Fasting plasma glucose has also been very topical and has been identified as an independent predictor of mortality in patients with COVID-19, with and without diabetes. And in the light of this, it's quite interesting to note that the ACE2 receptor requires glycosylation to be able to link with the SARS-CoV-2 virus. Initially, this process of glycosylation seems to be reversible, which suggests that if we intervene with regards to glycemic control in individuals with and without type 2 diabetes, we might alter the outcome with regards to the COVID-19 virus infection in individuals with diabetes. This slide demonstrates the results of a cohort of 7,000 COVID-19 patients with or without diabetes that was retrospectively studied in China. And as you can appreciate, that individuals with type 2 diabetes had an almost 50% increase in all-cause mortality compared to individuals without type 2 diabetes. The authors subsequently compared outcome in patients with diabetes based on in-hospital glucose control. So they excluded individuals with diabetes with any episode of hypoglycemia, and then divided this 952 participants into those that were well controlled while in hospital and those that were poorly controlled. Poor control was defined as blood glucoses that exceeded 10 millimoles per liter more than twice in 24 hours. The all-cause mortality in this cohort of people with diabetes was 7.5%. Now, when you individually look at these sort of subgroups, you can appreciate that the well-controlled group had an all-cause mortality that was lower than the overall mortality in this population of 1.1%, but that there was a 10-fold increased mortality in individuals that was poorly controlled during admission for COVID-19, suggesting that inpatient glycemic control is a significant modifiable risk factor that we have to address if we want to improve the outcome in these individuals. It also has downstream consequences, and as you can appreciate from the other adverse events, such as ARDS, an acute kidney injury, as well as septic shock, that in individuals that are well controlled, there are a significant lower risk of other adverse events, specifically the acute kidney injury, as opposed to individuals that have poorly controlled glucose. The Open Safely collaborators from the UK investigated the death in hospital among people confirmed to have COVID-19, and they looked at various comorbidities. Now, most comorbidities, as we expect, was associated with a higher risk of COVID-19 hospital death. But what came to the fore, and which is quite relevant to our discussion today, is the fact that poorly controlled glucose was associated with a significantly adverse outcome compared to well-controlled glucose. This HbA1c was not performed in hospital. This was the most recent HbA1c available for these patients, suggesting that if we are able to adequately manage glycemia, even before an individual develops or contracts COVID-19, we can make a significant impact with regards to the outcomes. Just moving on to the pharmacological management of diabetes in the presence of COVID-19 infection, there's very little data available on anti-hyperglycemic agents. So various organizations have made recommendations based on experience and based on the inherent properties of the various anti-hyperglycemic agents. I'm just showing you one or two oral agents, but there's no question that the in-hospital management of diabetes, especially for severe hyperglycemia or for hyperglycemic emergencies, should be based on insulin. This slide specifically looks at metformin, and we know that metformin has many anti-inflammatory effects as well as sex-specific effects on TNF-alpha. And the question that these authors asked was, is metformin protective from the SARS-CoV-2 virus? And as you can appreciate, that there were much lower in-hospital mortality in the metformin group compared to the non-metformin group. And then when a Cox proportional hazard analysis model was performed, you can appreciate that in women, metformin played a significant increased protective role as opposed to men. Obviously, this result should be reciprocated in other studies, but suggesting that metformin is not associated, at least, with adverse outcomes in people with COVID-19 and mild to moderate infection. Another oral agent that is currently being studied in the presence of COVID-19 is the SGLT2 inhibitor dapagliflozin. And this study is currently underway, recruiting patients with mild to moderate COVID-19 with or without diabetes. So only one risk factor for the developing of the complications of COVID-19, such as hypertension, CKD, etc., etc. They are randomizing the individuals to 30 days of dapagliflozin or placebo, and the primary endpoint is the time to first event of all-cause death or morbid disease. And the rationale of this study is based on the positive outcomes on autophagy and the positive outcomes with regards to the pleiotropic effects associated with SGLT2 inhibitors. Looking forward to see the outcome. Now, the first study of COVID-19 to specifically analyze the effect of the disease in a hospitalized patient with diabetes was performed in 53 sites in France and included 1,300 patients with diabetes hospitalized for COVID-19. And this study showed that more than 2/3 of COVID-19 patients admitted to hospital were male. The majority had type 2 diabetes, and that an increased BMI, as you can see, was associated with adverse outcome with regards to death and with regards to the risk for mechanical ventilation or death. A significant proportion of these patients with diabetes were uncontrolled, as you can see, an HbA1c of 8.1%. And a significant proportion of them had the company diabetes skips other than obesity. So this is the microvascular complications such as diabetic kidney disease and also macrovascular complications that in itself predisposes to adverse outcome with regards to any infection. So in conclusion, from a diabetes perspective, essentially nothing is different. This pandemic only highlights what endocrinologists and diabetologists have always known, that diabetes control is important. It is important before you develop an infection. It is important while you have that infection. And despite the fact that nothing is different, everything has changed. And with this, I hand over back to the chair. Thank you.
Thank you very much, Dr. Coetzee, for that very nice presentation. We will do questions and answers at the end of the entire presentation. And in fact, Dr. Roberto Pequoa, Professor of Nephrology at the Pontifical Catholic Hospital Paraná in Curitiba, Brazil, will be the moderator of the questions and answers at the end of the presentation. And now I'd like to introduce our second speaker, Dr. David Chariton, who's a director of the Division of Nephrology and a Norman S. Wickler Associate Professor of Medicine at the New York University School of Medicine. He was previously the director of the ICU Nephrology at Brigham and Women's Hospital and Associate Professor of Medicine at Harvard Medical School, where he also served as the Director of Renal Research at the Baim Institute, an academic contract research organization. In addition to maintaining a broad clinical practice in general nephrology, Dr. Chariton is an active researcher where they focus on diabetic kidney disease and cardiovascular disease in the setting of chronic kidney disease. Using large databases, translational cohort studies, and clinical trials to explore his research interests, Dr. Chariton has published more than 150 manuscripts and has served as the principal investigator on multiple grants with continuous funding by foundations and NIH since 2006. And now Dr. Chariton will be discussing the effects of COVID-19 and kidney disease. Dr. Chariton.
Thank you, everyone. Thanks for attending today. I'll talk a little bit about the kidney-specific impacts of COVID-19 and also the how we dealt with some of the kidney impacts and the stresses that has involved. and some of the creative thinking to get around that. Briefly, my disclosures are shown here. Nothing that's really specific to COVID, but I have had funding and consulting related to diabetic nephropathy with a couple of different sponsors, as well as in the area of acute kidney injury. Word of background, I think everyone in this audience most likely knows this, but there are a multitude of mechanisms responsible for progression of kidney disease in general and diabetic kidney disease specifically. And I'm not going to go through everything on this slide, but just to focus on a few of them that we'll talk about today, the angiotensin, renin-angiotensin, aldosterone cascade is a critical player in progression of kidney disease and diabetic kidney disease, in particular with angiotensin 2, in particular on the efferent side, increasing intraglomerular pressure. Oxidative stress and inflammation may be important in progression of acute and chronic kidney disease. And then we've really begun to recognize the importance of tubular glomerular feedback and the SGLT2 inhibitors in particular as a mechanism of progression for kidney disease. And then lastly, not shown on the slide, but hyperglycemia and perhaps hyperinsulinemia itself play important roles in progression of kidney disease. And I will talk a little bit about how how those might impact kidney disease in the setting of COVID and how we might treat it. Again, treatment paradigm would be blood pressure less than 130 based on the SPRINT results. There's been a lot of talk about whether we should target blood pressures even lower than that, perhaps not in the setting of diabetes, but I don't think anyone would take issue with a target of 130 over 80. ACE and ARB to a maximal tolerated dose. SGLT2 inhibitors have in the last year or so become critical players, and I would argue the standard of care for patients at risk for diabetic kidney disease. Although with the caveat that the benefits are less clear at the very lower end of EGFR, stage 4 and 5 CKD, and also less clear benefit in the setting of normal albuminuria, although there are some suggestive analyses that have been published in abstract form at this point, and in trials that didn't exclusively enroll diabetic kidney disease. And then best evidence for canagliflozin, empagliflozin, and dapagliflozin in terms of benefits on CKD progression in diabetic kidney disease. The GLP-1 agonists seem to have benefit so far. The benefit is more proven in the setting of cardiovascular disease associated with diabetes, and less clear, at least in terms of hard endpoints for diabetic kidney disease. And then published recently, or rather not published, but top-line results released recently for finrenone, which is the selected aldosterone antagonist, not yet on the market, but very promising top-line results released suggesting a very significant benefit of an aldosterone antagonist on progression of diabetic kidney disease. And while not published yet, I think those results are probably not surprising given what we know about the renin-angiotensin cascade and the benefit of aldosterone antagonists, at least in small trials on albuminuria as an endpoint. So how does that play into the issue of COVID and kidney disease? Well, a word of background that when we first began to encounter COVID, the early reports, primarily from China, but even what we learned from Italy, did not really suggest a very high rate of kidney involvement. This was really presented as a pulmonary disease and a severe one with sepsis-like syndromes, but and a high mortality. but acute kidney injury was not really part of the picture. And I'm not showing you all the manuscripts that were published here, but this is a typical, albeit fairly small, case series where the top line result is shown here is there's no risk of kidney injury, does not result in acute kidney injury in 160 hospitalized patients from Wuhan. And in fact, the early studies that came out generally showed roughly 5% involvement in kidney disease. And you can see here, a bunch of the earlier publications and going down the risk, a much larger study. AKI was only 0.5%. Interestingly, a higher percentage of patients in this study needed CRT. Presumably that was some end-stage renal disease patients, although a bit unclear. You can see again, in the long study, 3.6%, only about 1.5% needing renal replacement therapy, and so forth. Rates, for the most part, between about 0.5 and a high of 7%, although that was in a very small study, and very low rates of CRT or intermittent hemodialysis required, with the exception of these last two fairly small studies down here. But even in this last study, the ZAO study, only 5% of patients, of all hospitalized patients needing renal replacement therapy. As the disease crossed over the ocean to the US, we really discovered that for whatever reasons, and I can speculate on that, but the rate of kidney injury in the New York experience, and it's playing out in the rest of the US now, but mostly not published yet, there were much, much higher rates of kidney injury, roughly actually an order of magnitude higher. So I'm showing you here probably the first large and comprehensive study. So this was more than 5,000 patients from the Northwell system in the New York area. It's a double-digit number of hospitals that make up this system in greater New York. And you can see that almost half of patients had stage 1 AKI, and then when you get to stage 2 AKI or 3, where you're talking about significant kidney injury with a doubling of creatinine and changes of that matter, or creatinine over 4, you can see that again, a high proportion, 22% with stage 2 and 31% with stage 3, and overall, overall a third of patients had some degree of AKI. And sorry, I put that awkwardly before. More than a third of patients had AKI overall, with more than half of those patients having severe AKI, and about a third of those with AKI having the most severe degree, stage 3. Moreover, you can see that while this was an early publication, so many of the patients were still in the hospital at the time of publication, fully a third of the patients with AKI had died at that point, and half, about 40% were still in the hospital. Presumably, a similar proportion of those patients died. So an overall mortality for AKI, that would probably end up being in the 40% or more range. And in terms of risk factors, apropos to our discussion today, background comorbidities, including diabetes, were risk factors for development of AKI, as well as factors suggesting greater overall severity of illness, with more vasopressor use or need for ventilation, being very significant risk factors. You can see among those who were ventilated, there was almost an 11-fold increase in the risk of AKI. And lastly, interestingly, these authors showed, and I would say not terribly surprising, that as the illness grew more severe, so around the time patients began to need ventilation, as shown in this bottom panel here, that was when the onset of AKI was primarily. Moreover, about 5% of all patients in the hospital, so that's needed renal replacement therapy. That is, if you think back to the experience that was published out of China, some of those studies had as low as 1 or 0.5% of patients having any AKI at all. So again, a tenfold higher rate of patients needing renal replacement therapy, compared to those just having AKI alone in the prior experience. So much more severe presentation, it seems, in the US, and fully 14% in this series of those that AKI needed RRT, and a very high mortality among those who required RRT, about 55%. Again, realizing that slightly less than half of the patients who required RRT were still in the hospital at the time of publication. And as I mentioned before, diabetes, hypertension, CVD, as well as severity of illness were risk factors for having AKI. It seems like I missed a slide here, but let me just see if it's out of order. Okay, I seem to have missed a slide, but what I would summarize is that there have been since a couple of publications as well as work that we've submitted but hasn't been published yet. In terms of AKI, most of these series have found in the US, primarily in New York, but also one of these series is in New Jersey. That about 30% of COVID hospitalized patients are having AKI. About 5%, just like in the series I showed you from Northwell, were requiring renal replacement therapy, so had the most severe degree of AKI. And among those admitted to the ICU with severe illness overall, about 1/5 of those patients were requiring renal replacement therapy. For the most part, in our series in which almost everyone had been discharged, we just had single digits among more than 4,000 patients still in the hospital. Mortality among those in the ICU and requiring renal replacement therapy was above 70%. And I suspect that that is probably the overall estimate once you account for the fact that the early series included many patients, in a rush to publication, who were still in the hospital at the time of publication. About 80% of patients who do survive do seem to recover renal function and come off dialysis, or even get back to a number close to their baseline kidney function. So this does seem to act like acute tubular injury in other settings with a high mortality if you need renal replacement therapy in the ICU. 70% is on the high end of estimates from other series with other illnesses, but not out of the ballpark. And recovery is common among survivors. You have to survive to recover, and that's, the odds are not necessarily in your favor for surviving. But if you do survive, likelihood of recovering kidney function coming off dialysis does seem to be high in this disease as in others. And lastly, not covered in the Northwell series, or at least the data I showed you, is that as opposed to garden variety acute tubular necrosis and acute kidney injury in sepsis, many of these patients present, roughly 30 to 40% or more have proteinuria, hematuria, and leukocyturia, as opposed to only having granular casts on their urine sediment. So there, suggestion at least that there is some kind of inflammatory element to this disease, and at least something a little bit different pathologically, or in addition to ATN that we see in other settings. Which brings me to what's the pathology of this disease. So an early publication from China suggested that perhaps explaining, so 26 autopsies in which they were able to get renal pathology in patients with COVID-19 disease. They found red blood cell aggregates in the peritubular capillaries. That perhaps explains the hematuria. And then they found a little bit of thrombotic angiopathy. And then lastly, they posited that there were viral inclusions as shown in the second panel from the right, that there were viral inclusions primarily in the paratubular, in the tubules, but also in podocytes. And they suggested that they could detect them, as you can see here with immunofluorescence. So again, to summarize, diffuse tubular injury, erythrocyte aggregates, and some evidence of vasculitis. No evidence of vasculitis. And just to show you panel A here in the upper left, they were positing these were viral particles, also B, C, and D in various compartments. In panel E, they found a case of IgA nephropathy. And then you can see, interesting pathology. We looked at this as well. There were 7 post-mortem exams. In this case, we found that goes along with the thrombotic angiopathy they found in the prior case series, and in our experience of lots of clotting and DVTs and pulmonary embolism in these patients, that there were platelets-rich thrombi in basically all the organs that we looked at. This is in press in the E-clinical medicine. So that included the renal vessels. We saw megakaryocytes in much higher than usual numbers in the lung and heart, but also in the kidney, suggesting perhaps a mechanism of platelet and megakaryocyte activation, perhaps explaining the thrombosis. As I mentioned, we found paratubular fibrin and microthrombi in the renal vessels, as well as acute tubular necrosis as seen in the prior series, and some red blood cell and granular class in the paratubular capillaries. I would say we found what we thought were viral inclusions as well, and you can see, here megakaryocytes is shown with the arrowheads in various organs, as shown here in the kidneys in panel C. So very suggestive of a hyperactive platelet organization. Lastly, another case series, and some of these authors have just published yet another case series that was published after I made these slides last week. But in this case series, 10 patients with AKI. You can see 8 had severe AKI requiring renal replacement therapy, age of 65, and they saw ATN in all of the patients, as shown here. You can see flattened tubular epithelium and some sloughing over here. They found collapsing GN in one case, and that's been reported in a few case series of collapsing GN, rare, but a couple of case reports at this point. Myoglobin CAS, that goes along with the rhabdomyolysis that we've seen in many of our patients, perhaps as a mechanism for ATN in these patients. Of course, patients may have background in diabetic nephropathy that may predispose them. Panel E is a case of severe ATN or diffuse cortical necrosis from profound ischemia, presumably. One case of placentic GN as well. And in this case series, they were negative for the SARS-CoV virus. And they also found, again, some cases of thrombotic angiopathy in 2 out of the 10 patients. What I would, and then lastly, along with the cortical necrosis that I showed you in the last case series, there has been some evidence, as shown in this slide, of diffuse cortical necrosis seen on imaging. So profound ischemia, either from hypotension or more likely from thrombosis to the renal arteries in these very thrombotic patients. So What I will summarize before going on to this slide is, the pathology seems to be mostly ATN as the dominant mechanism. Some of that may be stimulated by rhabdomyolysis. There may be cortical necrosis from ischemia, thrombotic angiopathy in some patients, and then rarely there may be glomerulonephritis or nephrosis from collapsing GN or a crescentic sort of autoimmune process, and some of the patients with hematuria or high level of proteinuria may reflect those mechanisms as opposed to just ATN, but those do seem to be more rare presentations. Regarding the question of viral, direct viral invasion, the renal tubules in particular, but also the podocytes may express ACE2, the receptor. I'll come to that in a bit. But to date, RNA for virus has not been discovered or detected in the renal biopsies, and there have been significant questions about whether those so-called virus particles I showed you before are actually viral particles or what we are multivesicular bodies and not virus at all. And I would say the dominant sense right now is that they're probably multivesicular bodies and do not reflect direct viral infiltration into the kidney, although I would say the book is still open and it has been shown in the lungs. The kidney picture, I would say the evidence is unclear and probably, despite those pretty pictures that showed you earlier, does not support direct viral inflammation. So in terms of outcomes for patients with AKI and ESRD, AKI I showed you earlier. What about CKD and ESRD patients? As you can see here, the story for ESRD patients is perhaps a little bit better than the AKI patients. So as you can see here, a case series of ESRD patients, only 31%, it's a high number, but not like the AKI patients. 31% of patients died with ESRD who were admitted with COVID. And we have unpublished data that suggested an even lower rate, about 25% of our ESRD patients who were admitted with COVID died, compared to about 24% of all patients. In contrast, the CKD patients do seem to have a higher risk of death from COVID, on the order of 30 to 40% with admissions. So in concert with their background risk factors and high rates of diabetes, but the ESRD patients do seem to be different, and that held true in our unpublished data, even in the setting of ICU admission with a lower rate for the ESRD patients than the overall COVID population. As you might imagine, having all this AKI really placed a stress on resources to provide renal replacement therapy. We published this early on, noting that with tenfold higher rates of AKI and renal replacement therapy than we had been led to expect, and much higher rates than we see in normal times with garden variety admissions to the ICU or to the hospital. We were in this place all over New York where it was difficult to provide that much dialysis. And there were a few and while the focus was on ventilators, it really needed to be on whether there was enough dialysis to go around. Another factor is published in the New York Times that impacted this, as you can see here. To do dialysis, we have to have a nurse in the room all the time, and that, especially as PPE was in short supply in the early days and people weren't taking precautions at home or on the subway, we and many hospitals in New York lacked the number of nurses we needed to deliver dialysis as they went out sick. The other factor that impacted this was also, as more ICU beds were needed, ICU staffing changed, and so we ended up having more ICU beds, but a lower nursing to ICU bed staffing ratio, and that impacted the ability to deliver CRT. So, there were many impediments, a lot of AKI, loss of hemodialysis physicians, but to a much more important extent, nurses to deliver dialysis. PD was an option, but you need people to place PD catheters, especially acutely. Many centers don't have that capacity or that experience. ICU staff and dialysis staff lack experience with PD. There were shortages of supplies for kidney replacement therapy, so shortages of cartridges for renal replacement therapy, shortage of the bagged fluids that we use for CVVH, and resistance of staff in a really busy time to learning new procedures like trying to roll out PD, which requires less resources, but you're trying to roll that out, acute PD, at a time when your staff is busy and overwhelmed already. Just to recap, the available modalities include intermittent hemodialysis, conventional machine, and HD nurses that might not be available in some centers during COVID or that are stretched too thin. CVVH, it's probably the most widely used modality for hemodynamically unstable patients, but was compromised by lack of supplies and this change in staffing for ICU nurses. And peritoneal dialysis, which is out of favor in New York and in the US, is an acute modality, but has been used in many other parts of the world. It's slow and continuous. It's good for hemodynamically unstable patients, but does require catheter placement and ideally with flexible catheters that are usually used for chronic rather than acute PD. But just to show the endocrinologist who may not be familiar, you have a catheter in the abdomen and you can just attach it to bagged fluids. You can actually, with extension tubing, have everything done outside of the room except one hookup per day is shown here. Patients in the room, the PD fluid and the cyclers are outside of the room if you're doing automated rather than manual PD, but you can do manual. And without going into too much detail, we rolled this out in New York at my hospital and did 40 patients with a rapidly started acute PD program of 38. And while mortality was 63%, that's actually lower than the mortality of 75% or so we saw at our sister hospital, that's the private hospital, just a couple of blocks away, where CVVH was the dominant modality. We have no peritonitis, so I think this can be done with flexible catheters in this population safely. We were able to do it in prone patients. There's been some concern about that because you fill the abdomen up with fluid, but it did not interfere with ventilation as long as you coordinated with the proning team so that you had access to your catheter when patients were proned. And we were able to do it in obese patients with an aggressive regimen where we went up on volume over the course of just a few days. So we were able to do it, rapidly scale it up, requires many fewer resources, and because it's a very simple modality, if you're doing manual PD, nurses or physicians or PAs can learn to do this very quickly. We teach patients to do this at home over the course of a week or so. Turning just to the treatment of diabetic nephropathy in the setting of COVID, I just want to review that the receptor for COVID or SARS-CoV-2 is the ACE2 receptor. There's been some theory on ACE inhibition potentially leading to an upregulation of the ACE2 receptor and therefore more viral binding, leading to worse disease. In contrast, as shown in the lower panel, Ang2 plays a role not only in progression of kidney fibrosis, but also in the progression of lung fibrosis and downstream inflammation and oxidative stress. And thus, it is theoretically possible that blocking Ang2 activity, either with ACE or inhibitors or ARB, might actually reduce the risk of severe COVID-19, even though you might get more viral binding. Conversely, aldosterone antagonists and much the same concerns that you might have more ACE2 around. On the other hand, if you block aldosterone, you're going to interrupt downstream fibrotic pathways for inflammation and fibrosis that may play very important roles in ARDS and the lung complications, as well as kidney failure. In fact, on a basic science level, a very interesting study looked at this because this was a really hot topic. Should you withhold ACE inhibitors in ARB or not in the setting of SARS or risk for SARS? And so in this study, they looked at single cells from living donor kidneys, diabetic kidney disease kidneys, and kidney injury. And without going into too much detail, proximal tubular cells, where the bulk of acute tubular necrosis occurs. It's in the S2 segment of the proximal tubule, at least in animal models. There is a lot of ACE2 expression. It's primarily there. It is upregulated in diabetic kidney disease versus living donors, suggesting a reason why diabetic patients might be at increased risk of COVID-19 associated AKI. However, there was no change in the ACE2 receptor level with antagonism of RAS, suggesting, at least in a basic science model, that ongoing use of ACE and ARB should be safe. In fact, a very large study from NYU looking at administrative data in this study, using multivariate modeling of epidemiologic data, they found no increase in the likelihood of either a positive test for COVID-19 or severe COVID-19 among patients with any of 5 antihypertensive medications, including ACE or ARB. A second paper had much the same findings. So this is 6,272 patients, 30,000 controls, inpatients and outpatients. They looked at mineralocorticoid receptor antagonists and ACEs and ARBs. As you can see here, there was no risk in adjusted analyses of an increase in risk of COVID-19 related disease with ACE or ARBs at all. And much the same for RAS. Unfortunately, that got cut off on that slide. On the whole, I think you can give them safely to your patients with some caveats I'll come to later. What about SGLT2 inhibitors? There's no specific data on the risk of AKI for COVID that I'm aware of at this point in time. However, they might increase the risk of volume depletion in AKI, and I think what we found clinically in the early days, because of the severe pulmonary disease and the x-rays that sometimes look like patients have volume overload, a lot of these patients were being dried out, and that probably contributed to acute kidney injury. Often patients weren't being examined by every team member in an effort to conserve PPE. And I think that's something we need to be aware of in the patients, and SGLT2 inhibitors could contribute to some volume inhibition. There is a risk of DKA with SGLT2 inhibitors, and that will go up in critical illness. On the other hand, they may have anti-inflammatory effects, and probably many of you are aware that IL-6 inhibitors have been looked at quite closely as a potential therapy for COVID-19, and there is an ongoing study, as shown here, the DIR-19 trial of dapagliflozin, looking at an SGLT2 inhibitor as a treatment for COVID-19. So on the theory that it may reduce lactate, reduce oxygen consumption in the kidneys, activation of alternative RAS pathways, and decrease pro-inflammatory cytokines. What about GLP-1 agonists? As I mentioned, so far the data on kidney disease in general is promising but not proven for these agents. There's some evidence that liraglutide in particular, but probably representative of the class, may upregulate the ACE2 receptor, which, as mentioned previously, could increase risk for for AKI and severe COVID disease. On the other hand, they may decrease, and they could also impact cytokine release. That might have a beneficial effect. So unclear with these classes, with this class of medications, whether to anticipate a benefit or a risk from this class of medication. So what I would say in summary is there's clearly a high risk of AKI in COVID-19. It's primarily from ATN, but there may be a role of with rhabdo contributing to some of that ATN. We need to be aware of volume status, as I mentioned previously, although that's more from experience than actual data. There may be thrombotic angiopathy in many of these patients as well, and perhaps some degree of autoimmune activation in the kidneys with collapsing GN or presentic GN. As of yet, the data on direct viral invasion unclear. Diabetic patients do seem to be particularly at risk, and there's a high mortality when you get AKI in the setting of COVID-19. I would say overall, the current data are insufficient to recommend for or against specific changes to our therapeutic strategies in the absence of an admission for COVID-19. Given the effect of ACE and ARB and aldosterone antagonists, as well as SGLT2 inhibitors on volume status and hemodynamic regulation, as well as for SGLT2 inhibitors, the risk of ketoacidosis, I would argue that it's prudent to consider discontinuing those in patients once they are hospitalized. But again, I don't have data to speak to that. And in terms of, are there any specific therapies for patients to prevent AKI? I would say not yet. Obviously, the dexamethasone data and the remdesivir data are promising in terms of having some effect. Patients with significant kidney injury were excluded from the remdesivir trials, but there's been an argument that the drug probably can be given, although in practical terms, whether you can get it released for that purpose, I'm not sure. There are some trials ongoing or about to start to look at specific therapies, but nothing proven so far. And I believe that is my last slide. So thank you, everyone.
Thank you so much, David. And I'll take it from here. And I know that we are a bit ahead of the schedule for the finished, but hopefully we'll be able to entertain some of the questions that were asked in the Q&A icon there. Maybe I'll start with a question to Anke from a few of the of people in the audience regarding hypoglycemic agent discontinuation when patients are admitted with COVID infection, particularly metformin.
Yeah. Thanks, Roberta. It's very difficult because there's not a hard and a fast rule. In clinical practice, I mean, there's been this concern about lactic acidosis with regards to metformin. That's usually in the context of organ hypoperfusion and another reason for lactic acidosis. Having said that, in the presence of acute kidney injury and so forth, I'm very reluctant to continue the use of metformin, despite being some data in the intensivist sphere that it might actually benefit some patients with sepsis. I also think that, one needs to approach this rationally and ask yourself to what extent will metformin contribute to the glycemic environment. And we know that metformin, from a risk-benefit ratio point of view, metformin would not contribute significantly to improve glycemia in the setting of severe disease. So no clear answer. I think you have to individualize therapy. Also, remember, there's not uniformity in terms of which patients are admitted. We are currently seeing that because people are becoming more and more aware of diabetes and COVID-19, people are admitted to hospital with very mild disease. In those patients, I don't see the risk, necessarily of continuing metformin if they are admitted just for the purposes of monitoring. But I think you have to have significant clinical vigilance and reassess these patients frequently because things change. And the moment that you see a change in condition, suggesting that someone moved from mild to moderate COVID-19 infection, I would suggest that you scrutinize the oral anti-hyperglycemic agents as well as some of the injectable agents, including the dosages of insulin from an injectable point of view.
Well, thanks very much. Now for you, David, there's been some questions here about the risk of nephrotic syndrome in patients with COVID, and maybe we can expand that to some of your thoughts about the long-term consequences of the infection.
Yeah, so it's a really good question. So I would say there are clearly patients who do, there have been, as I mentioned, a few case reports of patients who develop collapse, biopsy-proven collapsing GN in the setting of COVID-19. In addition, I would say of the patients that I personally rounded on, there are a few who, profound hypoalbuminemia. When you measure their urine protein, it seems to be at a very high level. Some of those patients were too sick to really biopsy, and I don't know, was that just sepsis and capillary leak, or did they have a kidney-specific issue? I suspect, given the pathology that we've seen, at least some of those patients actually have some kind of glomerular disease, whether it's collapsing GN or something else.
Yeah, thank you.
In terms of long-term consequences, I don't think we know yet. The disease has only been around for a few months. I suspect, those who are unfortunate enough to develop collapsing GN probably will have long-term consequences and need to be treated, with similar regimens, so that's a guess. For those with ATN, if they have severe ATN requiring renal replacement therapy, I think the data from other diseases suggested that those patients, even if they recover to a normal creatinine, are probably at, an increased relative risk of developing long-term CKD or ESRD, but the absolute risk if they recover to baseline, is probably pretty small. Yeah,
and I'm sure that there are ongoing initiatives to follow up those patients, and previous examples like for HIV, for instance, that, after many years, we understand the long-term consequences that might be, similar in here. So more to come, I guess. So back to you, Ankia. There's a question about the need for monitoring cortisol levels in diabetic patients treated with corticoids.
Yeah, generally, in terms of cortisone replacement therapy, we know that there are various agents that interferes with the assays. So if you measure the cortisol levels, for instance, if you're using hydrocortisone, you're just measuring what you are giving. So there's no utility really in that perspective. With regards to dexamethasone, we know that we use dexamethasone to suppress the endogenous cortisol levels, and that those agents are not picked up generally in the assays. So in terms of the utility of measuring cortisol levels in people with diabetes, I would say in the context of acute illness, only if you suspect Addison's disease or cortisol deficiency. Over and above that, if you use vasopressors, we know that we have to add steroids to improve the receptor functioning. But other than that, I'm not familiar with the utility of routine measurement of cortisol levels, giving cortisol replacement in people living with diabetes.
Well, thanks very much. And I'm sorry, but I guess we'll take just a couple more questions here because of the time. So for you, David, again, there's a question here about the potential dangers of keeping patients on SGLT2 inhibitor because of the glomerular hemodynamic actions of this treatment. So would you, I mean, I know that there's ongoing studies talking about the use of this, but I mean, is there some concerns about, especially with patients with hemodynamic instability?
Yeah, I think so. Somebody flashed up a question while I was talking. I couldn't absorb all the same. There may be more recent data since I finalized my slides last week that was not reassuring. From what I saw, there hasn't been much published on SGLT2 inhibitors at COVID specifically. I would say certainly in the setting of admission, with COVID-19, I think my comments would mirror what Annika said about metformin. I think these are patients who come in, they can turn fairly quickly from fairly stable to pretty sick, and in that setting, I think it makes sense to limit your use of agents that may promote hypotension and volume depletion. Unless you're specifically trying to think the patient's volume overloaded at that point. I think in the outpatient setting, there's really no data to suggest that we should be withholding these agents out of fear that someone might get COVID-19. But in the admitted patients, I think it's probably a reasonable, although not data-driven strategy to withhold them at this point.
Well, thank you very much, and thank you also, Anke, for your answers and for your talks. People really appreciate it. There's a lot of comments in the chat about the quality of the presentations. And I think for the sake of time, we'll stop the Q&A now, and I'll just go back to you, Mark, for your final comments.
Thank you very much. I'd like to thank all the panelists today for their very nice discussions. Just in that last point about SGLT2 inhibitors, I would emphasize the lack of need for their being used in the hospital. I mean, they have benefit for cardiovascular renal benefit, but those are long-term benefits, not short-term. And the risk for volume depletion, possible increased risk for ketoacidosis, I think outweigh any possible benefit. Patients need insulin in the hospital. It's pretty simple. So again, I'd like to thank everybody for their participation with this. And I hope that our people listening to this have gotten some useful information for management of their patients. And hopefully this whole thing will improve over time, and our COVID-19 will gradually decrease as it comes under control around the world. Thank you.